Hi, my name is Sarah Lashinsky,
And I'm Heather Gartrell.
and today we're going to present a patient case, an appropriate treatment plan, and discuss education and monitoring, and these will be assessed from the perspectives of pharmacy and nursing.
Our patient, henceforth referred to as FW, her chief complaint is, I hate sticking myself with needles, but metformin doesn't work.
Her history of present illness includes FW is a 67 white female presenting with a complaint regarding her current type 2 diabetes regimen. Over her lifetime, her lifestyle has contributed to her current type 2 diabetes state. She reported that she currently has a sedentary lifestyle. She reports that she gets minimal exercise and considers her only exercise to be going to the grocery store or walking to get the mail. She has a hard time controlling her diet because she loves to cook, and she admits to eating unhealthy. She's experienced weight gain, and she's commonly fatigued. In the past, she has smoked 2.5 packs of cigarettes per day for 30 years, but she quit in 2005. She has had high blood pressure for 3 years and high cholesterol for 14 years.
In terms of a past medical history, we have atrial fibrillation, hypertension, dyslipidemia, thyroid disease diagnosed in 1977, type 2 diabetes for the last 15 years, rheumatoid arthritis, kidney failure, anxiety, insomnia, and edema of the lower extremities.
From a pharmacy perspective, I was concerned with whether or not all of these disease states are controlled, if she's currently taking medications to control all of these disease states, and whether or not she's compliant with those medications, whether or not the side effects are tolerated, and if there are any drug-drug interactions.
From a nursing perspective, the main point here is all the factors regarding teaching related to her type 2 diabetes. In terms of a past surgical history, her surgical history is significant for thyroidectomy and hysterectomy. A family history, our patient is actually adopted, so there is no known information on her biological parents or family history. Social history, again, former smoker, smoked 2.5 packs of cigarettes per day for 30 years, but quit in 2005. No alcohol consumption or illicit drug use. She is unemployed, married, and she lives with her husband. In terms of allergies, FW has seasonal allergies and an allergy to penicillin.
Her current medication list includes insulin aspart protamine and insulin aspart 70-30 mix, calcium acetate 667 milligrams. She takes renal caps multivitamin, levothyroxine 125 microgram, carvedilol 6.25 milligram, rosuvastatin 20 milligram, cholecalciferol 1,000 units, and aspirin 81 milligrams.
As we proceed to her review of symptoms, FW's review of symptoms is significant for the following constitutional symptoms: weight loss, weight gain, night sweats, and fatigue. Her psychiatric symptoms were anxiety and insomnia. She had no complications dealing with neurology or hematology/lymph. Regarding HEENT, she reported infrequent nosebleeds, vision problems/neuropathy, negative for glaucoma or cataracts. FW reported several musculoskeletal issues. These included joint aches, leg weakness, muscle cramps, and rheumatoid arthritis, as well as peripheral neuropathy and numbness. Her endocrine symptoms include diabetes, again, duration of 15 years, and thyroid disease, duration 37 years. She reported no respiratory complications. Regarding her cardiovascular health, FW reported atrial fibrillation, high cholesterol, and high blood pressure. She reported no gastrointestinal symptoms. In regards to genitourinary complications, FW has kidney failure, diagnosed 2 years ago. She reported swelling of her legs. Regarding her immune system, she mentioned seasonal allergies and an allergy to penicillin.
And again, from a pharmacy perspective, I was concerned with whether or not all of these are being treated, and if she had any of these symptoms from her current medications. For example, the muscle cramps and the musculoskeletal issues could be from her rosuvastatin, so changing to another statin might be in order for her.
In terms of the physical exam, the patient appeared pleasant, talkative, and older than her stated age. She appeared not very well rested, as observed from almost squinted eyes with dark lines around them. She was not at all anxious or distressed. FW was very calm and spoke with an in-depth understanding of her disease states and medication. Furthermore, the patient had somewhat of a loss of control attitude when discussing her medications. This was noted from her constantly saying phrases like, "Oh, well, I just have to take it," and, "Well, what else am I going to do?" Although she did not know her vital signs or lab values, she mentioned that she does have high blood pressure and high cholesterol, and that all of her other lab values should be normal. She mentioned that she was low on vitamin D and calcium levels, but has since improved the values via supplementation. Her physical appearance in regards to HEENT appeared normal. Her breathing sounds were normal, and she did not seem short of breath at all. Her skin appeared normal in color and moisture, not pale or dry. She did have swelling in the lower half of both of her legs.
A medication-related problem prioritization list was designed. The medication-related problem that we gave high priority to was drug selection not optimal, and the details included the Crestor 20 milligrams causing myalgia. So switching to another statin might decrease her musculoskeletal pains, or maybe decreasing the dose. Another problem we found was a clinically significant drug interaction. She is currently taking her levothyroxine and calcium acetate together in the morning, and it is recommended to take them 4 hours apart. Calcium salts have been shown to diminish the effect of thyroid products. So that one was given a high priority as well. Of medium priority was needing additional drug therapy. Her rheumatoid arthritis is not treated. Another additional therapy that she needs is for edema. She could take something like Lasix. We would have to keep an eye on her glucose, however. Another additional therapy that she needs is for her insomnia. So she could try Ambien. The Beers criteria suggests to avoid ongoing use. However, it says that it's okay to take for a short term, which Ambien is recommended for 10 days. So she could try that along with sleep hygiene. She also needs additional therapy for her anxiety, which is not being treated. The additional therapy for insomnia and anxiety were given low priority as they weren't immediate complaints that the patient had.
In terms of subjective data, the patient presented with complaints about painful and annoying insulin injections. She smoked 2.5 packs of cigarettes per day for 30 years, but quit in 2005. She's no longer able to engage in moderate physical activity. She complains of vision problems, retinopathy, weight fluctuations, swelling in the legs, and leg weakness. Our past medical history of hypertension and hyperlipidemia were also stated, and her insulin aspart protamine and insulin aspart 70/30, 25 units sub-Q each morning and 20 units sub-Q each night since 1999. Objectively, there is edema in both lower legs, and no lab values were provided.
The assessment part of the SOAP note for this patient is as follows. FW is a 67-year-old white female diagnosed with type 2 diabetes mellitus. Due to multiple comorbidities such as hypertension, hyperlipidemia, and renal failure, FW was started on insulin aspart protamine and insulin aspart 70/30 mixture. She takes 25 units sub-Q every morning and 20 units sub-Q every evening. She started this approximately 5 years ago. She stated that she tried metformin once, but it did not adequately control her glucose values. She's compliant with her current regimen, but she would prefer to not have to use a twice-daily injection, so by-mouth regimens must be considered. Metformin has been shown to improve mortality and lower A1C and blood glucose values by the greatest extent. However, because this didn't work before, and now she currently has kidney failure, which is a contraindication, metformin is no longer an option. The alpha-glucosidase inhibitors were considered, and they are not the best option either because they only lower the A1C by 0.8 or 0.3 to 1%. The glitinides class lowers the A1C by 0.8 to 1%. The thiazolidinediones are not reasonable because they can worsen edema and they can also cause new onset heart failure. She currently has edema in her legs and has cardiovascular complications, so that's definitely not an option. And peripheral edema is also observed for the DPP-4 inhibitor class, so these are a poor choice as well. Regarding sulfonylurea medications, A1C and fasting blood glucose values are lowered to the same extent as metformin. Thus, if metformin didn't work, the sulfonylureas likely won't either. The patient inquired about long-acting insulin injections, such as insulin glargine, which is a once-daily regimen. However, based on research in the literature, it's been shown that the Novolog mix is superior to insulin glargine. as far as controlling glucose values. Based on her current compliance and adequate control of her diabetes, it is reasonable to maintain her current regimen. However, FW should be counseled on methods to alleviate discomfort with injections.
For the plan portion, the goals of therapy, we'll address patient education in just a minute, but the goals are to control blood glucose, alleviate discomfort at injection site, improve quality of life, and decrease risk of noncompliance. The pharmacologic plan is to maintain current regimen on Novolog mix and record fasting blood glucose values with careful attention to potential hypoglycemia. The non-pharmacologic plan is to improve dietary choices to include more fruits and vegetables while minimizing or eliminating fried foods, red meat, and foods high in fat or cholesterol. Other non-pharmacologic plans include develop non-pharmacological methods for addressing pain with injections and to increase physical activity even to a mild degree.
As far as monitoring parameters, she should be monitored for efficacy, including close monitoring of blood glucose as directed by the physician, and obtain blood work for A1C values periodically. For toxicity and adverse effects, she should be monitored for her plasma glucose, where the normal range is 60 to 110 fasting. She should be monitored for her electrolyte levels. Her HbA1c should be measured the normal value is less than 7%, and she should be monitored for injection site reactions. She should follow up to schedule an appointment and get her lab values checked in 2 weeks.
So now we will move on to the patient education portion. Patient education as far as the type 2 diabetes is a major concern for both nursing and pharmacy. So in terms of patient education, she should be advised to never use a needle more than once. Try as best she can to relax the muscle at the site of injection. If using an alcohol swab, let it completely dry before injection. And speak with her doctor about different needle sizes, as well as possibly bringing up the idea of an insulin pen, which may just make it easier and hopefully a slightly less uncomfortable injection. Never inject cold insulin, always inject it when it's at room temperature and to penetrate the skin quickly.
She should be counseled to take a missed dose as soon as she remembers, but if it is too close to the next injection, skip the missed dose and continue as normal. Do not take 2 doses at the same time. The insulin should be stored in the refrigerator or at room temperature. If it's stored at room temperature, the unused portions should be discarded in 28 days.
FW should be advised that she may still experience some irritation at the site of the shot, but be aware that severe reactions may occur, and if she experiences any of the following, she should contact her doctor immediately. Chills, fast breathing, changes in eyesight, very bad irritation at the injection site, muscle cramps, abnormal heart rate, itching, hives, swelling, and slurred speech. Any
changes in blood glucose values or eating habits should be reported immediately, as those adjustments may be required. Low blood sugar can occur with the use of insulin. Contact your physician immediately if you notice a large drop in blood sugar values. Blood work should be checked often. Talk with your doctor to discuss appointments. Check blood sugar as directed by your doctor, and take the insulin at the same time every day.
Another important teaching is to rotate the sites. Abdomen, outer thigh, outer arm, upper buttocks area. Just be sure to not continue to use the same site over and over again, and to always wash hands before each injection.
The solution should appear uniformly white and cloudy. This is important to know because a lot of insulin solutions are to appear colorless, so this one in particular should be white and cloudy. And any needles should be thrown away into a sharps container, and when the box is full, follow the local rules for disposing. An outdated drug should not be used, and it's important to follow the diet and exercise plan as directed by the doctor. It was a very interesting experience for us to work together on this project. It showed us that we really need to pay attention to other disciplines, and that one discipline might not have all of the important information, and questions that I thought were super important didn't come to mind from a nursing perspective, and similarly from a nursing perspective, the things that she brought up didn't come to mind for me immediately. And I think that seeing from both perspectives gives the best, most comprehensive treatment plan for the patient.
and I wholeheartedly agree.
Thanks!
Thank you.